Well, a very good evening to everyone. So I hope you are all ready for the ride quizzes, the next 20 quiz. And I wish everyone should actively participate. It's a very simple questionnaire today, straightforward questionnaire. Let me see how many are on the go. So it's dot 9 and the quiz takes around 25 to 27 minutes. Fine, we'll wait for another 1 minute and we'll see if any players will join. I hope it's running live. So we do have invisible players. Okay, then I hope we shall start. Start the quiz. Okay, still. Okay, so I think it's enough waiting. We wait for almost 2 minutes. Let's see. Let's go with the first question. Let's start the quiz. Yeah, there you go. The first question. Which of the following factors is associated with decreased risk of developing ovarian cancer? Yes. Okay, that's a good number. We have more players. Come on, let's start the quiz. Yep. First question. There you go. I've already read it out. I hope you even see the answers. Most of you must have. This time, everyone should write it well because I've discussed this. There's a bonus question for everyone. PBC and PSC, primary biliary sclerosis and primary sclerosing cholangitis. Primary biliary cirrhosis and primary sclerosing cholangitis. So, what's the right answer? Yes, I hope most of you have listened to my explanation previously. So, let me skip this question. Okay. Next. So, who is Dinu, Suhi, Pari, JD? Right. Okay. Next question. Which of the following is characteristic of lung cancer? All types have association with smoking, has a bad 5-year prognosis, is decreasing in incidence in women, small cell carcinoma presents as a hilar mass. So, what's the answer? Yes, very good. I am happy that majority of you wrote it correct. See, all types are not associated with smoking. Okay, and you have small cell lung cancers, and you have adenocarcinomas, and you have. I mean, how do you classify lung cancers? Small cell and non-small cell lung cancers. So now all types of cancers have association with smoking? No, that's not the right answer. Has a bad 5-year prognosis? It depends. Okay, if you have a very good prognostic, I mean, if you're diagnosed early, the prognosis is quite good. Is decreasing in incidence in women? No, it is actually increasing in incidence in women because of the rate of increase in smoking, which has increased. And small cell carcinoma, most of it, like more than 90 to 95% of cases present as a hilar mass, okay, near close to the bronchi. So that is the characteristic feature of lung cancer. Next question with the leaderboard in between. Okay, good. I wish the other 5 to join more. Next question. A typical cause of a chronic bacterial prostatitis in sexually active 30 to 45-year-old males is HPV, HSV, HIV, chlamydia trachomatis. It is a bacteria. Good. And why someone has opted human papilloma virus? It is bacterial prostatitis. I think that's a virus. All the other 3 are virus. This is bacteria. Chlamydia trachomatis. What does it cause? Lymphogranuloma venereum. Okay. And it is chlamydia trachomatis. It is responsible for even infectious cause, and you can even prevent it. But what it causes? Blindness. Okay. The most common cause in India for infectious blindness is chlamydia trachomatis. Okay. And what other? Fine then. We'll go with herpes simplex virus. No. HIV. No. Okay. Next question. Next. Question number 4. The most commonest mode of inheritance in von Willebrand's disease. So what is it? See, there are a few things which you should remember. Codominant, autosomal recessive, autosomal dominant, X-linked recessive. Very good. Autosomal recessive is the correct answer here. What is codominance? Codominance is where we have 2 different alleles and they both give their role in the individual. So what are the examples for codominance? For example, blood grouping system, A, B, O. Mother is A and father is O. Okay, so you have both. They codominantly express. Okay, that ABO blood grouping is a very good example for codominance. Autosomal recessive. So what examples do you have for autosomal recessive? You have sickle cell anemia, you have Tay-Sachs disease, you have cystic fibrosis. Okay. Autosomal dominant. What do you have? Majority of diseases like Marfan syndrome, Huntington's disease, these are all autosomal dominant, like adult dominant polycystic disease. Okay. X-linked recessive, they are hemophilia A, hemophilia B, they are all under X-linked recessive. Okay, next question. I wish you all should have written it correct. But majority, it is autosomal recessive. The answer is autosomal. Okay, question 5. The following conditions are associated with increased risk of skin malignancy. Bowen's disease, acanthosis nigricans, squamous papilloma, and keratoacanthoma. Good, I'm happy. Bowen's disease is the right answer. It is also called as in situ squamous cell carcinoma. Acanthosis nigricans is a manifestation of internal malignancy, the external skin manifestations with an existing internal malignancy. Squamous papillomas, benign. And keratoacanthomas, histologically, we see a crater-like thing, okay, like a lava inside the epithelium lining, and then you find it like a crater, okay. Keratoacanthoma is not associated. Given a Bowen's disease and a keratoacanthoma can be ruled out, okay. So it is Bowen's disease, which has more incidence. Okay, next question. There, Sairam is there. Shweta ready. Okay, fine. Next question you have. All of the following malignancies are associated with HIV except Kaposi sarcoma, non-Hodgkin's lymphoma, astrocytoma, gastroadenocarcinoma. I think you should answer all. Everyone should answer this. Gastroadenocarcinoma, they usually get it. Okay. I think the mechanism behind it is the commonest infection, H. pylori, and then it is eventually it will land up into ulcers and fine. Astrocytoma, yes, that's the right answer. Non-Hodgkin's lymphoma, yes, you do have non-Hodgkin's lymphoma. You can find them in bone lesions or anywhere else. Okay, there's lymphoma chances are very high in such patients. Kaposi sarcoma, it's always associated with HIV. Okay, next leaderboard, please. Okay, Pari, Suhi, Sairam, Shweta Reddy, Chintu, 5. Okay, fine. 7 question. So, okay, fine. The question is like 49-year-old male has alcoholic liver disease. Now, what according to you is the mechanism with which this patient liver is injured? So, is it because of decreased fatty acid delivery to the liver, decreased production of triglycerides, increased mitochondria oxidation of fatty acids, increased NADH production? So, what according to you is? Yes, I'm happy that 4 of you wrote correct and 6. See, how does alcohol harm this liver? Okay, so alcohol, it produces hepatic steatosis with increased fatty acid synthesis, decreased triglyceride utilization, decreased fatty acid oxidation, decreased lipoprotein excretion, and increased lipolysis. So now what happens is the ethanol that is the alcohol which is taken up by the liver is converted to acetaldehyde, okay, by alcohol dehydrogenase. And this also, and in this pathway there is conversion of NAD and NADH. Okay, so that is how there is increased NADH production is there, ultimately leading to the hepatic steatosis due to increased lipolysis. Fine. Next question. Next question. Okay, Pari is on the top today. In peripheral blood picture, smudge cells are seen in. This is a simple question. Smudge cells. Smudge cells are the cells which, when you give a peripheral smear, when you try to do a smear, they get crushed. The cells get crushed. Okay. So is it an ALL, CLL, AML, or CML? Very good. CLL. I don't think people needs more explanation for this. Okay. So due to this excess number of cells, they are blasts. So bigger in size, and then when we try to spread the slide, they easily get crushed and they form like a basket. Okay. Or you can remember the parachute kind of cells. Okay. Those are called smudge cells. Smudge is nothing but crushed. You have smudge biopsies we do for neurologic cryo stats. Like if a patient is on table, okay, is undergoing a surgery, the clinician wants an immediate diagnosis. What do? You go for frozen sections. So what frozen sections are ideal for neurological situations like astrocytoma or anything? What we do, we just take the surgeon will give us a small tissue bit. So we take it and we crush in between two slides and the tissue is processed. Okay, that is smudge biopsies. Smudge. Okay, next question. Good. Fine, let's go to the next question. Pari is still on the lead. Sairam is moving forward. Which of the following statements is more characteristic of ulcerative colitis than of Crohn's disease? Which is more towards ulcerative colitis? Fibrosis may produce a blockage. Inflammation begins in the rectum and extends proximally without skip lesions. Microscopy may reveal transmural inflammation with non-caseous granulomas. Sudden abdominal pain may result from intestinal obstruction. So what's the answer? Yes. Majority wrote inflammation begins in the rectum and extends proximally without skip lesions. So now what is the difference between, what is the commonest point between these two? They both are inflammatory bowel diseases. Now what are the differences? Ulcerative colitis, it is more prone to develop into cancers. Okay. And what does the patient have? The patient will develop bloody diarrhea. And in ulcerative colitis, the inflammation is only mucosa and submucosa. Okay, it's only superficial. While when you come to Crohn's disease, it is transmural, it invades totally. That's why there is something called skip lesions. It can occur from mouth to the anus, anywhere Crohn's disease can occur, less likely in the colon. Okay, so this Crohn's disease, what do you see histology? How does they look like? They have cobblestone appearance. When you see through the gastroscopy or endoscopy, you see the cobblestone morphology of the GIT. Okay, so that is Crohn's disease. Any point I missed between Crohn's? Skip lesions are a characteristic feature of Crohn's. Fissures, obstructions are features of Crohn's. Okay, fine. That's a leader. And granulomas are a characteristic of Crohn's again. Okay. Next question. Berry aneurysms, which is false, most often found in the circle of Willis, result from atheroma, result from abnormalities in the medial wall of the arteries, are associated with polycystic renal disease, which is false. They do not result from atheromas. Very good. Majority wrote it correct. I don't think this is a favorite question for many of you all. You must have read about it well, huh? Berry aneurysms. Fine. Okay. They're most often found in circle of Willis. That's true. Okay, let's go to the leaderboard. They are associated with polycystic kidney disease. Okay, Sairam is pushing. Very good. Shweta Reddy, Chintu. Okay, come on. Keep up the pace. Next question. See, think twice. Which of the following is quick and inexpensive way to differentiate between CML and elevated white cell count, like in leukemia reactions? Is it a bone marrow test, or is it a CT scan of the abdomen and chest, leukocyte alkaline phosphatase stain, and ultrasound of the spleen? So what, according to you, is the quick and inexpensive way? Wow, that's nice. I thought I need to explain this question, but you're all practically very good. Bone marrow is expensive. CT scan is expensive. Ultrasound is expensive. So, but what is this lab score? Leukocyte alkaline phosphatase. What is it? Is it increased or decreased in CML? It is decreased. It is increased in like leukemoid reactions. Why? Because leukocyte alkaline phosphatase. So what does it do? The more mature the cell is, okay, so you will find that in bigger quantities. In CML, you find more blasts, so less amount of leukocyte alkaline phosphatase is found. So that is one way why there is lab score is low in CML and high in leukemoid reactions. Okay, next question. Let me see who is moving, whose graph is moving forward. Leaderboard, please. Okay. Oh, see there, Sairam is moving. Good. Next, a patient with Ewing sarcoma. Histology shows small round cells. These cells are filled with which of the following? Is it glycogen, iron, fat, mucin? Ewing sarcoma. I'll give you a clue. PA stain is positive when you do this. Ah, yeah, very good. So it is glycogen. Okay. So periodic acid shift stain is positive, and glycogen is a component of basement membranes also. Okay. Good. It's not iron, it's not fat, and it's not mucin. Okay. Fine. Mucin is seen in mucinous adenocarcinomas. Fat is seen in liposarcomas, but it is distorted. Iron is seen in is it seen in any type of malignancies? Of in cells in a malignant condition, no hemochromatosis. Yes, when you pick up the liver, you find the iron stain, or normally you will find in bone marrows. Okay, okay. The next question. Oh, good, Pari. Keep it up. Sairam, keep moving up. Which of the following types of hepatocellular injury is commonly seen following acetaminophen overdose? This was the question which was repeated even the last quiz. I hope you all will answer it right. Acute hepatitis, centrilobular necrosis, fibrosis, and granuloma formation. Please don't miss the quiz because the questions are repeating. So repeated questions needs no explanation. Very good. Everyone wrote it correct. Fine. Next question. Acetaminophen overdose hepatocellular is because of centrilobular necrosis. Fine. Next question. Oh, okay. Good. A 50-year-old patient presents with a lesion in the midline involving the sacrum. It's found to be sclerotic. What is the most probable diagnosis? Metastatic chordoma, osteosarcoma, chondrosarcoma. Involving the sacrum and it is in the midline. What do you have in the midline? You have the cord. Yes, it is chordomas. It's not metastatic. Metastatic bone lesions, it is you don't find near sacrum. Osteosarcoma's most common location is it is not sclerotic. It is osteolytic, and it is distal part of the femur. And chondrosarcomas they occur in the places where there is cartilage and the bone, most commonly near the ribs and all. Okay, you have predominant cartilage and the bone. Then there is this metaplasia. Okay, so the answer is chordoma. Fine. The next question we have. Oh, Sairam is on the top. Good. So here the question is, a 37-year-old man presents with a single firm mass within the thyroid gland. So you find organoid nests of cells separated by broad strands of stroma. The stroma positively stained with Congo red. Okay, I think that's enough for the question. Follicular carcinoma, papillary carcinoma, squamous cell carcinoma, and medullary carcinoma. Congo red stain. Very good. It is medullary carcinoma. Now, what are the features of this individual? Let me tell you. Medullary carcinoma, most commonly seen in patients who have chronic diseases, and men and female are equally affected. Okay, but whereas most common thyroid lesions in females are benign, and in men, if they come, they are malignant. And when you come, most common cancer in female, it is papillary carcinoma of thyroid. Okay. So what do you find in follicular carcinoma? There is capsular invasion and there is no lymph node involvement here. It will directly metastasize. Okay. Follicular carcinoma. Papillary carcinoma, you find histologically different sized follicles where the follicles are lined by very often any type of nuclei. Okay, pale clear nuclei will be there with nuclear grooves and ridges, coffee bean like structures. Then squamous cell carcinoma, you found the sheets and nests of cells. Medullary carcinoma, you find this amyloid, which is extracellular. Okay, collection of this uh, pigment. Fine. The next question: who is on the bow? Who is on the top? Let me see this. Ah, Sairam. I think now it is difficult for you all to pull him down, so it's better you all try to actively participate in this. Next question. A tan, flat, 1 centimeter rough surfaced non-tender papule in a 19-year-old man. So, hepatic dermatitis, syphilitic chancre, tinea versicolor, and verrucae vulgaris. So, what is it? It is verrucae vulgaris. Okay. 19-year-old man, non-tender papule. Fine. It is not herpetic dermatitis where there is itching. There is a lot of itching. And it is a rash. It is not a papule. Okay. And syphilitic chancre, it is painful. And it is most common in the genital regions. Tinea versicolor is hypopigmented patchy lesions. Okay. It is fungal infection, not it. So verrucae vulgaris, the clinical picture says it is verrucae vulgaris, which is most common. Okay, fine. Next question. There's a picture for it. I think that is not displayed. Fine. Next question. So here a male patient comes to the physician's office complaining of a non-tender ulcer on the penis and has been present for a week. So they say there is spirochete and it is Treponema pallidum. It is VDRL positive. So now, how does this affect it? Granulomas with suppuration, granulomas with caseation, acute inflammation with abscess formation? Yes. So the answer is syphilis. The patient is suffering from syphilitic chancre. So now, how does syphilis play a role? It produces obliterative endarteritis with perivascular lymphocytes and plasma cells. So this is how the syphilitic mechanism starts. Okay, granuloma with suppuration is seen in, if suppose there is any foreign body invasion, you find granulomas, and then there is suppuration. Okay, even fungal infections and all. Now granulomas with caseation, it is seen in tuberculosis. Acute inflammation with abscess formation, any bacteria. So obliterative endarteritis with perivascular lymphocytes and plasma cells is a feature of syphilis, which is caused by Treponema pallidum. Okay, fine. Next question. There, okay, fine. Sairam is on the lead. Next question. Which of the following constitutes the normal flow of the aqueous humor? So, is it from the anterior chamber to aqueous veins to canal of Schlemm and trabecular meshwork? Or is it from the anterior chamber to posterior chamber? Or is it from canal of Schlemm to episcleral veins? Or is it posterior chamber to anterior chamber? So which line you see? If you know the first thing, the answer is right. Yeah, remember this mnemonic called PATS. PATS. Okay, PATS. So P for posterior chamber. From where is this aqueous humor secreted? It is secreted by the epithelial lining of the ciliary processes. Okay. So from the posterior chamber, you have paths. Posterior chamber to the anterior chamber and to the trabecular meshwork and to the canal of Schlemm and then to the episclerotic veins. So this is how the flow chart goes. Okay. Spectrum of this aqueous humor in the eye flow. Fine. Next question. Who wrote it correct? Okay. Next question. Which of the following is true regarding Liebman-Sachs lesion? Causes perforation of valves, involves multiple valves, consists of large vegetation. Vegetations on the surface of valves spreads to mural endocardium. Causes perforation of valves, involves multiple valves, consists of large vegetation. I don't think so. Yes, very good. A happy majority wrote it correct. So this is a straightforward question. SLE, Liebman-Sachs endocarditis, or you can find it SLE endocarditis. So there are vegetations on the surface of the valve. They are even seen in both atrial valves and ventricular valves, and even they spread to the chorda tendineae as well. Let's go to the next question. Last question of the day. So here a 22-year-old female who has malaise, pharyngitis, couple of weeks. She has Raynaud's phenomenon. Yep. Next question. She has Raynaud phenomenon and has infectious mononucleosis. Her direct and indirect Coombs were positive at 4 degrees, although not at 37 degrees. So, which of the following is correct? Is it immunoglobulin E? Is it complement C3b, histamine, or immunoglobulin G? So, here, what is the patient having? Clearly, it is cold agglutinin disease, okay, because she is having a positive Coombs test, both direct and indirect at 4 degrees, okay. And remember, IgG is a warm antibody, G, garam, okay. IgM is cold antibody. But when I say cold agglutinin, is there an IgM? No, the IgM is not the answer here. So because we don't have it as an option. Now IgE is type 1 hypersensitivity. So the patient is not having any type 1 hypersensitivity. Histamine is again a manifestation of any inflammatory sign, but we don't find any. So now what does this IgM eventually do? It will eventually activate complement C3b. So that is what is the mechanism of injury here. So for her, the following red blood substance in her red blood cells are more, which is complement C3b. So that concludes our quiz today. So let us see who is on the line. Who is on the line? Who has crossed the line? The leaderboard, please. Okay, so that ends our quiz. I hope you all enjoyed it, and I wish you all to study more and more and do participate in the quiz actively. There you go, Sairam. Fantastic. You're on the lead. So, and I want every one of you to participate actively in the quiz. No lot more short, because when you practice, you will not forget it. Okay. So that's all for the day. Good night. Study well.